Good afternoon, everybody. Thank you so much for joining. This is the ONC CMS information session, information blocking, disincentives final rule. My name is Josh Shapiro with Capital Consulting, and I'm going to be assisting today with the logistical support for the session. We will have the Q&A enabled today, so you can ask questions by clicking that Q&A button at the bottom of your screen. We will also allow the raise hand feature to be used to ask questions verbally towards the end of the webinar if you choose to do so. Additionally, we ask that you select the speaker view option located at the top right side of your Zoom interface, and this will allow you to see the speaker as they present or share their information. Any technical assistance, please click the chat icon at the bottom of your screen, type in your question into the chat to myself, the host, and I will respond to you and help you out. And finally, today's session is being recorded. Closed caption is available if you want to click the CC icon button at the bottom of your screen. And I will now turn it over to Alex Baker from ONC, who will officially kick things off.
Great. Thank you so much, Josh. My name is Alex Baker. I am Deputy Director in our Federal, State, Local, and Territorial Division in our Office of Policy, and I am going to be reviewing a little bit about the final rule that was just released. So next slide. So just a couple of disclaimers. This final rule was released on ONC's website on June 24th, 2024. This HHS approved document has been submitted to the Office of the Federal Register for publication and has not yet been placed on public display or published in the Federal Register. The document may vary slightly from the published document if minor editorial changes have been made during the OFR review process. And the document published in the Federal Register is the official HHS approved document. So important disclaimer about the status of publication. Next slide. So before I talk about this rule, I want to just include a little bit of background about information blocking, which was originally defined in the Cures Act, the 21st Century Cures Act in 2016, which defined information blocking as a practice that, except as required by law or covered by an exception, is likely to interfere with access, exchange, or use of electronic health information, or EHI. And the definition goes on to specify certain types of actors that can commit information blocking, and states that a health IT developer of certified health IT, health information network, or health information exchange, if one of these actors commits information blocking, such developer, network, or exchange knows or should know that such practice is likely to interfere with access, exchange, or use of EHI. And if a healthcare provider conducts information blocking, such provider knows that such practice is unreasonable and is likely to interfere with the access, exchange, or use of EHI. So for folks who may not be as familiar, want to make sure to mention up front that information block, this definition for information blocking and how it applies to different types of actors. Today, we are talking about healthcare providers, which are the subject of this final rule on information blocking disincentives. Next slide. Just another kind of fundamental piece around information blocking, which is the definition of electronic health information. That means electronic protected health information to the extent that the electronic protected health information would be included in a designated record set, as these terms are defined for HIPAA, including some exceptions for psychotherapy notes and information compiled in reasonable anticipation of or for use in a civil, criminal, or administrative action or proceeding. Next slide. And then want to make sure folks are aware of information blocking exceptions. So this was authority provided in the original Cures Act for ONC to develop information blocking exceptions. These are cases where conduct, if it meets one of these exceptions, would not be considered information blocking. And ONC, go forward 2 slides. Well, there we go. in 2020 released the 21st Century Cures Act final rule, in which we defined the exceptions here. We subsequently have done some additional revisions to these exceptions, including in our HTI 1 final rule, which was just released this year. Next slide. So last point about information blocking, while the law was passed in 2016 and we are continuing to release rules to implement the law, we have also been collecting information on information blocking claims over that period. And so would encourage folks, if you're interested in reviewing any of this information about what information we've received from the public around allegations of information blocking, that is detailed on our website, and you can learn more about the different types of folks who have submitted information blocking complaints, and you can also use this site to submit allegations of information blocking. Next slide. So today's final rule is the 21st Century Cures Act establishment of disincentives for healthcare providers that have committed information blocking. And again, that was released on June 24th on ONC's website. This rule builds on both the 21st Century Cures Act final rule that I mentioned in 2020, as well as a final rule released by the HHS Office of Inspector General last summer, which focused on enforcement of the information blocking regulations for other actors besides healthcare providers. The final rule will be effective 30 days after it is published in the Federal Register. So again, as noted, this has not been published in the Federal Register yet, and we do not have a publication date at the time of this webinar, but once that is published, the effective date will be 30 days after that publication date. Next slide. So a little more about the background for this final rule. As I mentioned, this is based on the 21st Century Cures Act, and specifically Section 4004 of the Cures Act, which added Section 3022 of the Public Health Service Act, which defines information blocking for the different types of actors I mentioned, including healthcare providers. And again, important to note the specific element of the definition that is focused on healthcare providers. Another way that the Cures Act treats different types of actors subject to information blocking differently is around enforcement. So for non-healthcare providers, the health IT developers, the health information networks and exchanges, the Cures Act said that those actors, if they commit information blocking and have been investigated by OIG, they can be subject to civil monetary penalties of up to $1 million per violation. And that is the penalties that OIG put into place through their rulemaking last summer. For healthcare providers, the Cures Act took a different approach and said that instead of these civil monetary penalties, if a healthcare provider is determined to have committed information blocking by OIG, they would be referred to the appropriate agency to be subject to appropriate disincentives using authorities under applicable federal law as the Secretary sets forth through notice and comment rulemaking. And so the final rule that we're discussing today is focused on this provision of the Cures Act and establishing these appropriate disincentives that healthcare providers who commit information blocking can be subject to. Next slide. So first want to mention who a healthcare provider is under the information blocking regulations. A healthcare provider was defined in the 2020 21st Century Cures Act final rule in 45 CFR 171.102. And it is the same definition as exists in Section 3000 of the Public Health Service Act. And as you can see, it is fairly expansive definition that includes many different types of healthcare providers that are called out by name in that definition. We'll return to this in a little bit, but we'll just note that the disincentives that we are finalizing today do not cover all of the different healthcare provider types that are included under this definition. Rather, they include a significant subset of those healthcare providers that provide care to Medicare beneficiaries. Next slide. So for the provisions of the final rule, we begin with a section that focuses on that provision of the 21st Century Cures Act around appropriate disincentives for healthcare providers, and include some final policies defining certain terms and defining how we are approaching the statute. So in this section, we finalize that the term appropriate agency means a government agency that has established disincentives for healthcare providers that OIG determines have committed information blocking. So perhaps a bit straightforward, but this can be any agency which OIG could potentially refer a healthcare or an information blocking determination to for a provider to be subject to disincentives, if that agency has gone through the rulemaking process to establish those disincentives. We also finalize a definition for the term disincentive to mean a condition that we specifically list in a section of the CFR that is imposed by an appropriate agency on a healthcare provider that OIG determines has committed information blocking for the purposes of deterring information blocking practices. And we state that an appropriate disincentive for a healthcare provider that OIG has determined to have committed information blocking could be any condition established through the rulemaking process that we determine would have the effect of deterring information blocking practices consistent with the 21st Century Cures Act. Next slide. So we go on to further discuss the provision of the Cures Act and how this is informed the current rulemaking. We reiterate discussion from the proposed rule about the important phrase in the Cures Act, authorities under applicable federal law, which we have interpreted to mean that an appropriate agency may only subject a healthcare provider to a disincentive established using authorities that it could apply to information blocking by a healthcare provider subject to the authority, such as healthcare providers participating in a program supported by the authority. And this is important to understand sort of the path that this regulation has taken, in that based on the Cures Act, we are looking at existing applicable federal law and using those authorities in order to establish these disincentives. We also note that an important clarification is that a healthcare provider may be subject to each appropriate disincentive that an agency has established through notice and comment rulemaking and is applicable to the healthcare provider. So there is no bar on each of the disincentives that have been established. If they're applicable to a healthcare provider, that healthcare provider could be subject to the disincentive. However, we note a modification around this policy in the final rule, in which we, as a modification to what was discussed in the proposed rule, we note that there may be scenarios in which an appropriate agency exercises discretion to not impose a certain disincentive under a certain authority. So under this policy, a healthcare provider could still be subject to more than one disincentive, but there may be scenarios in which they are not subject to a certain disincentive based on that agency's discretion. Next slide. Excuse me. So we next turn to a section around the OIG. Oh, sorry, just a moment here. And I'm back. Okay, so we next turn to a section around the OIG investigation and referral process for information blocking. As we noted in the proposed rule, and we reiterate in this final rule, it's important to note that there have been no regulatory proposals made around OIG's policies here. Rather, this is information that is provided for informational purposes only around OIG's process, and this significantly builds on information that OIG has already provided in their rule from 2023, focused on investigation and enforcement for those other actors that we talked about. An important note here in the final rule around the OIG investigation process is that the final rule states that OIG will not begin investigating healthcare providers until after the effective date of the final rule, and will exercise its enforcement discretion to not make any determinations regarding conduct occurring prior to the effective date of this rule for information blocking disincentives. So an important timing issue here that folks should realize that disincentives finalized in this rule will not be applied to conduct that occurs before the effective date of this final rule. This section also reiterates a discussion from the proposed rule about the anticipated enforcement priorities that OIG expects to use as they decide whether to investigate conduct that may be information blocking. These are practices that resulted in, are causing, or have the potential to cause patient harm, practices that significantly impacted a provider's ability to care for patients, practices that were of long duration, and practices that cause financial loss to federal healthcare programs or other government or private entities. So important to recognize that OIG will consider these factors as it decides where to spend resources in pursuing investigations. Next slide. This section goes on to provide additional information about the referral process. So noting that during an investigation of information blocking by a healthcare provider, but prior to making a referral, OIG expects to coordinate with the appropriate agency to which it plans to refer its determination of information blocking. And then once OIG has concluded its investigation and is prepared to make a referral, it will send information to the appropriate agency indicating that the referral is made pursuant to the statutory requirement. And that referral could include various types of information supporting the referral, such as the dates when OIG determined the information blocking occurred, analysis to demonstrate how the conduct meets the information blocking definition and is not covered by one of the exceptions, copies of evidence collected during the investigation, and any additional information that may be of use to the appropriate agency. Next slide. The next section of the final rule goes into certain final policies around the application of disincentives. As I noted, the finalized disincentives that have been established are listed in a new section of the CFR in 45 CFR 171.1001. This section also finalizes that the appropriate agency that imposes a disincentive or disincentives would send a notice to the healthcare provider that's being subjected to the disincentive using usual methods of communication. That this notice would include information such as a description of the practice or practices that form the basis for the determination of information blocking referred by OIG, the basis for the application of the disincentive or disincentives being imposed, the effect of each disincentive, and any other information necessary for a healthcare provider to understand how each disincentive will be implemented. This section also discusses the issue of appealing a disincentive and reiterates the discussion in the proposed rule, which states that a healthcare provider may have the right to appeal administratively a disincentive if the authority used to establish the disincentive provides for such an appeal. So an important issue for to note that we did not propose and have not finalized a new or separate process under which there would be administrative appeals for disincentives, but rather if the authority under which the disincentive has been established has applicable appeal rights, then those would be available to the healthcare provider under that authority. Next slide. So a final set of policies here, and then I will turn it over to my CMS colleagues to talk about the specific disincentives. So the final rule finalizes certain transparency provisions for all actors, including healthcare providers, subject to the information blocking regulations. So this is healthcare providers, but also health information exchanges, networks, and developers of certified health IT. And under these policies, we have finalized that we would publicly post information about those actors that have been determined by OIG to have committed information blocking in order to provide transparency into how and where information blocking is occurring within and impacting the broader nationwide health information technology infrastructure. So specifically on the ONC website, we would proceed with posting information about those actors that have been determined by OIG to have committed information blocking, including identifying the information blocking practices, the actors who committed information blocking, disincentives applied, or other information about the determination that's available from a government source. We have made several small modifications to this section from the proposed rule, including clarifying that we would only post this information after any administrative appeal process had been completed. So if a disincentive is applied under a certain authority and that authority includes administrative appeal rights, we would not post this public information until that has been exhausted. And with that, I am going to turn it over to Elizabeth Holland in CMS to discuss the first two finalized disincentives. Elizabeth?
Hi, can we go to the next slide, please? Great, thank you so much. My name is Elizabeth Holland, and I work I'm a senior technical advisor actually in the Division of Clinician Quality in the Centers for Clinical Standards and Quality here at CMS. Just so you know, Alex talked about appropriate agencies, and in this final rule, CMS is considered an appropriate agency for applying a disincentive for information blocking. So in this final rule, it's limited to Medicare and just a few provider types, as Alex explained, all the different healthcare provider types. But it is very possible that in the future we might propose additional disincentives for other healthcare provider types. But whatever we do, we would do through notice and comment rulemaking. So don't worry, you'll get a heads up and an opportunity to submit your input when and if we do that. So we have finalized our proposal that an eligible hospital or critical access hospital that commits information blocking will not be considered a meaningful EHR user during the calendar year of the EHR reporting period in which OIG refers its determination to CMS. The impact on an eligible hospital would be the loss of 75% of the annual market basket increase. And for a critical access hospital, if they're subject to the disincentive, they would have their payments reduced to 100% of reasonable costs instead of the 101 they might have otherwise earned. The thing is, if you are already not a meaningful user under the Promoting Interoperability Program, because you didn't demonstrate meaningful use successfully, this imposition of information blocking would have no additional financial impact on you because you only get that one penalty. However, ONC will be posting the names of those found to be information blocking by OIG. So that is a disincentive that's not financial, but probably reputational. Next slide, please. Now I'm going to talk about clinicians. So these are clinicians that are participating in the merit-based incentive payment system, or MIPS. So we finalized our proposal that a MIPS eligible clinician would not be considered a meaningful EHR user if OIG refers a determination that the MIPS eligible clinician has committed information blocking. As a result, if the clinician or group was required to report on the promoting interoperability performance category of MIPS, they would not earn a score in that performance category, which is typically 1/4 of their total final performance score. And so this could be a potentially big impact for clinicians. The payment threshold for 2024 is 75 points. So if you earned 75 points, mind you, if you're an information blocker, you get 0 for the 25 points of promoting interoperability. So if you earn 75 points, that's assuming you're perfect in the other 3 performance categories, you would get a neutral update for all your Medicare Part B payments in 2026. That works the same way for eligible hospitals. The EHR reporting period where you're not, when we get the referral from OIG, the payment adjustment applies 2 years in the future. We did modify one of our policies for the disincentive to clarify that if an individual MIPS eligible clinician is found to have committed information blocking and is referred to CMS, and if this individual generally reports as part of a group, if the group is not found to be in an information blocker, only that individual should be subject to the disincentive. So if this occurs, we would highly recommend that the group not include the individual in their data submission, and that the individual submit their data separately for that performance period where they were found to be information blocking. And now I'm going to turn over to Carrie Vandergrift.
Thank you, Elizabeth. I'm Carrie Vandrift. I'm a Deputy Division Director within the Center for Medicare, and I'm here to talk about the Medicare Shared Savings Program today. So within the Medicare Shared Savings Program, if a healthcare provider that is an ACO participant, or an ACO provider or supplier who is determined by the OIG to have committed information blocking, they may be ineligible to participate in the Shared Savings Program for a period of at least 1 year. In the case of an ACO applicant that is a healthcare provider, CMS may deny the ACO's application to participate in the Shared Savings Program for the upcoming performance year. For ACOs that are already participating in the Shared Savings Program, CMS may terminate the ACO's participation agreement. CMS has finalized in this rule that we will consider the relevant facts and circumstances before applying a disincentive under the Shared Savings Program. Relevant facts and circumstances may include the time since an information blocking conduct has occurred, the healthcare provider's diligence in identifying and correcting the problem, or whether the provider was previously subject to a disincentive in another program. Restricting the ability of healthcare providers to participate in the Shared Savings Program for at least 1 year will result in the healthcare providers potentially not receiving revenue that they might otherwise have earned if they had participated in the Shared Savings Program. Thank you. I will turn the presentation back over to Alex.
Great, thank you. Next slide. Okay. So just coming back to the point that I made at the beginning and that Elizabeth echoed, want to reiterate that the disincentives finalized in this final rule only apply to a subset of healthcare providers. However, as we state in the final rule, we believe that it is important to ultimately be able to establish disincentives that would apply to all of the healthcare providers defined in the healthcare provider definition that are subject to the information blocking regulations. We included a request for information in the proposed rule on this topic, seeking information about other healthcare providers that HHS should prioritize for future rulemaking and other potential disincentives using authorities under applicable federal law that could be applied to these other healthcare providers pursuant to notice and comment rulemaking, and got a lot of very useful input on that, which we expect to take into account. While there is no set date for when we would establish additional disincentives, we will be reviewing that input and continue to explore additional disincentives through future rulemaking that would apply to those healthcare providers that are not implicated by the disincentives finalized today. Next slide. There are resources available on healthit.gov about this final rule, as well as a broader set of resources about information blocking, what constitutes information blocking, the exceptions to information blocking, a wide variety of resources that have been developed over a number of years in response to public input and our previous rulemakings that we would invite you to take a look at.